All right, this is Dr. Castanet. I'm off camera again. This time I'm going to show you a low back MRI scan or lumbar MRI scan with a herniated disc. It's pretty apparent to anybody that looks at it, even a lay person. You can see the disc is sticking out right there. Now, when we look at these MRI scans, we have to orient ourselves in terms of the anatomy. And the easy way to do it in the lumbar spine is you find the sacrum at the bottom. The sacrum is 5 segments which fuse together. There's very often, as in this case, in fact I'd say usually, a rudimentary disc there. Just the vestige of the disc that was there before the sacrum fused in its 5 segments. We call the topmost segment S1. This would be S2, S3 would be down there, and you can't see S4 and S5. Anyway, that's how we orient ourselves in the low back. So this is S1. The vertebra above that is L5, the 5th lumbar vertebra. This would be L4, that's L3, that's L2, that's L1 up there. So coming back down here, you can see the canal back here, which is where all the nerves are, and the white cerebrospinal fluid and connective tissue there. That all looks normal with the exception of this disc right there, which is sticking out. When the disc contents herniate out like this, there's less content back here in the disc where it originated from. That means that the spine and the vertebra collapses on the one beneath, and you can see that this is a very thin collapsed disc as a result. This patient has had significant pain and sciatica for 4 months. That's not a long time. This MRI scan is only about a month old, and if you were to take an MRI scan of this person, say 2 months ago, there probably was a good deal of this present already, but it wasn't symptomatic, as it sometimes is not in some patients for quite a while, but it's very symptomatic now. It's very reasonable to do surgery if this was incapacitating or wanted to, it ruined her quality of life and she wasn't patient with the process and the pain was too much. That would all be a reasonable cause for taking out this disc in what we term a discectomy surgically. Those surgeries have a very good success rate, probably 90% success. There is, after a discectomy, about a 6% chance of reherniation, meaning that more of the contents can come out from there and reherniate out there sometime after the surgery. But that's not often enough to deter a person from doing the surgery or recommend against the surgery. Surgery usually makes a person feel better very quickly, and the outcome is very good from that. Nonetheless, there's always surgical risk, and surgeons, good surgeons, conservative surgeons, will tell you try everything else short of surgery first. It also, oddly enough, is more likely that a very large herniation like this will be resorbed by the body. So if the pain is not too severe, or the person can live with the pain, or find palliative measures or therapeutic measures non-surgically, then this may resorb with time and go away and become asymptomatic. And I would say in a case of a large herniation like that, that's probably the case more often than not. But it's also true that we don't know for sure if it's going to happen and how long it'll take. So if in the meantime it's too painful to live with, then again, surgery is a reasonable choice. In terms of non-surgery, there are a lot of things you can do there, but I don't think very many will be effective. You can't really exercise in a way that's likely to make that get better. The normal McKenzie exercises where you extend the low back while you're lying on your stomach, usually you're just going to aggravate this because the McKenzie exercises will make the canal smaller and less volume in the canal, but it won't affect this disc volume favorably, so it'll increase the relative volume of the disc in the canal and probably pinch the nerve more. What I do for these patients is I provide traction or spinal decompression. We try to pull these apart somewhat. If this disc fragment that's sticking out is still connected to this and still influenced by the disc in here, then pulling the vertebrae apart like that can encourage the disc to recede a little bit It doesn't have to recede a whole lot for this person to feel better until I think this will resolve on its own with time. So that's what I recommend for these cases. Now I'm going to show you another picture. We'll go to the next one, not that one, not that. That's different. That's different. Let's go back here. Shoot. Okay, going to go to the next one. This shows a different slice, same disc. You could see it sticking out considerably. There's some white here and there because these bones become edematous or swollen from fluid when the disc is out like that and the bones collapse. That means the circulation across here, which is normal, is impaired, and as a result you get swelling of the bone immediately adjacent to the disc level. I'm going to go to the next slide. Again, it's a little different slice, but you still see significant sticking out of the disc right there. Again, this is a better view to see the bone edema there in the L5 vertebra there. You see it to a lesser extent down here in the S1 segment. Go to the next one. Same thing, sticking out a lot. On a scale of 0 to 10, well, I'll show you what I mean in just a moment. We're going to go now to a cross section. If you cut across here and look down, you can see this in cross section, and that's what this image shows. You see the white material? The white area there is what the whole thing should look like. All this here should be white, but there's dark tissue there and very dark tissue there. This is all disc fragment material that should not be there. On a scale of 0 to 10, I would say the severity of that relative to what we usually see in disc herniations is probably, I'd say, a 7, something like that. It could be bigger. This patient and anybody with a very large herniation must be advised, by the way, that the surgical emergency, when you absolutely have to get surgery, is if it affects your bowel and bladder in such a way that you either become incontinent, meaning you soil or wet yourself, or you can't go to the bathroom. Either of those would be an indication for getting surgery to remove that and get the pressure off of the nerve roots that run to the sacrum and your bowel and bladder as soon as possible, meaning typically within an hour or as soon as possible. The longer pressure is on those nerves, if those nerves are compressed significantly and your function of those bowel and bladder are impaired, the longer the function's impaired, the more likely it is to persist permanently. So that's a surgical emergency. Short of that, people need surgery based on their pain, and if the pain's not severe, irrespective of what the disc looks like, you don't have to get surgery. But anyway, you see all this mass should not be there. It should all look that white color, right, all there. Now, I want to orient you because it so happens that there's more right there. That is actually on the person's left side. And the reason I say that is because the image here is oriented such that this is the back of the person, the belly of the person would be up that way, and the person's laying with their head at the far end and the feet at the near end. I've discussed this before with you. If the feet are at this end and the head is at the far end and they're laying on their back, that means that this over here, yeah, that means that this here is the right side of the person. This is the left side of the person. So since most of this disc mass is on the left side, then the nerve roots, which are on this left side here, are compressed and causing sciatica pain down the left leg. Anyway, that's about as much as I have to tell you about this MRI scan. If I can help you with your back pain or sciatica, I'm Dr. Castanet in Decatur, Georgia. My number is 404-558-4015, and my website is backstrong.net if you want to learn more or watch more videos on my blog about the nature of spinal pain. I welcome you. Thanks very much. Bye-bye.